So hi everyone, welcome to our finals crash course series lecture on paediatrics. This is part 2 of our paediatrics lectures and it's on cardiorespiratory diseases, taught by Dr. Kalpana Jayasinghe. And if you look on the top right of this slide, that's the link to our Instagram page. So please do follow and then you'll get all the kind of updates on our upcoming sessions. And on the bottom left is just our email address. So if you have any questions about the session today or about anything going forwards, then please feel free to email us and we'll try and reply as quickly as we can. And then next slide. So this is the link to the polls for the day. I'll post it in the chat as well. So if anyone joins late, then they can join. But I'll give a few seconds for people to join. Yeah, it's in the chat now as well. So
okay.
Yeah, I'll hand over to you, Kalpana.
Perfect. Hi, so good evening. My name is Kalpana Jayasinghe and I'm currently a PEDS as a trainee. And today's topic is on cardiorespiratory conditions, so the common conditions that we see that might come up in exams. And I would also thank Med Crash Course for giving me this opportunity to teach. So yeah, let's get started. So we are going to start with a scenario. So you are a PEDS trainee, a PEDS SHO, who has been called by a midwife as 4-hour-old Samuel turned blue whilst crying. He was born at term by normal delivery. Her mother was unaware of the pregnancy and had no antenatal care. So what would be the best next investigation that you would do? Pre and post ductal saturation, chest X-ray, echo, cranial ultrasound scan. And I give you guys some time to answer the question. Perfect. Okay, and yep, so what you would do is you probably will do most of those investigations, but the first thing that you would do is history, examination, and a pre and post ductal SATs. And up in doing it, you found that the pre-ductal SATs is 90% and the post-ductal SATs is 85%. And this is the chest X-ray of little Samuel. After seeing this, what do you guys think is the likely diagnosis? So transposition of great arteries, atrial defect, ventroseptal defect, or tetralogy of Palate. And I will just go back to the X-ray so you guys can have a look at it again. Okay, I will stop the poll. Correct. And the correct answer, as most of you guys answered, is transposition of great arteries. Why and how? So how can you work on the scenario? So the way I usually go on is I just take like key information from the stem of the question. So you have a 4-hour-old Samuel that was born at term by normal delivery and seemed to be fine. And you know that mom had no antenatal care, so she did not have a routine ultrasound scan. So you do not know whether anything was unusual during the pregnancy. And as an SHO, the first thing that you would do is a pre and post ductal SATs. And on the chest X-ray, what you characteristically see is the boot shape. I would just show it like there. And that is a characteristic finding of transposition of great arteries. So yeah, so we are going to talk about congenital heart diseases. And as you can see from the table, we can classify it as usually in 2 categories, acyanotic and cyanotic heart disease. So acyanotic means that there's enough oxygen so that it does not cause cyanosis, whereas in cyanosis, the abnormality or defect cause a low level of oxygen and the individual or the child becomes cyanotic. And usually it's like a bluing or discoloration of the skin or the oral mucosa. And I'm just presented like the commonest ones, but obviously there are more acyanotic and cyanotic conditions. So acyanotic, we have atrial septal defect, ventroseptal defect, patent ductus arteriosus, coactation of aorta, aortic valve stenosis, uncyanotic, common ones, especially for exams, tetralogy of Palate, transposition of great arteries, and tricuspid atresia. We're going to touch up on some of these conditions. So before we go on to it, just a quick recap on fetal circulation, how it differentiates from our childhood or adult circulation. Anaya, do we have anyone on the chat? Or is anyone online?
We have 2 people with us.
Fine, perfect. Any of you guys could tell me what we see in fetal circulation, how like fetal circulation is different from the childhood or like adult circulation? If you don't know, if you don't want to answer, that's completely fine. Okay, that's fine. So the main difference is that we don't have the pulmonary exchange. So the lungs are filled with air. So the lungs are filled with fluid. So as a result, we don't see the normal gas exchange in the lungs. Instead, the placenta takes over the role. And we have foramen ovale, patent ductus arteriosus and ductus venosus, which kind of are parts of the heart that we do not normally see in child or adult anatomy. And what will happen usually is blood flows from the placenta via the ductus venosus into the inferior vena cava. From the inferior vena cava, it enters the right atrium, and majority of the blood here is now oxygenated and nutrient rich, and it is then pumped from the right atrium into the left atrium. Some of them then goes from the right atrium into the right ventricle, and majority of them gets shunted via the ductus arteriosus from the right ventricle into the left ventricle, where then that blood gets pumped via the aorta to all parts of the body. A very small portion actually goes from the right ventricle via the pulmonary artery into the lungs, but no gas exchange takes place. It returns into the left atrium, into the left ventricle, and then gets pumped to all parts of the body. So i.e. the main difference is that the blood that is received in the right atrium is oxygenated and nutrient rich. Majority of the bloods get pumped directly from the right atrium into the left atrium via the foramen ovale. Some of the blood that has entered the right atrium actually goes down to the right ventricle, and majority of them again gets shunted from the right ventricle into the left ventricle via the ductus arteriosus. Again, a very small portion actually gets then pumped from the right ventricle via the pulmonary artery into the lungs. From the lungs, it then gets back into the left atrium, left ventricle via the aorta to all parts of the body. So that's our normal fetal circulation. And it is on some of these aspects where things can go wrong and you end up with congenital heart disease. One particular one is ASD, also called atrial septal defect. The name itself kind of gives an idea of what is abnormal. So defect means there's a defect. Where is it? In the atrium. And where in particular, it's in the septum. So it's a hole in the septum that divides the right atrium and the left atrium. And based on where along the septum that hole is, we can classify them in different types. The most common type is ASD secundum, and that is often the foramen ovale that fails to close. We have ASD primum that's found more towards the AV junction. We have coronary sinus types and sinus venosus. What causes ASD? It is not always a clearly know what the underlying causes for ASD. In some cases, it might be sporadic. In some cases, there might be already a family history of ASD, and that increases the likelihood of the child having ASD as well. And there's also some elements of environmental and genetic factors. So this is just a quick picture, just demonstrating a normal heart, where we can see the right atrium, the septum being complete, and then we have the left atrium, whereas in ASD, you can see the septum and there's a hole. So as a result, what will happen is when the baby takes their first breath, when they're born, we know that the pressure on the left side increases. And what now happens is with the hole being present between the septum, some of the blood from the left atrium is shunted into the right atrium. That's something that we do not want to happen. It seems to happen slightly more in female than male. It can be either found on its own, or sometimes it could be associated with other cardiac defects like tetralogy or Palate. And as I mentioned earlier on, an individual would be slightly at higher risk of having ASD if there is a family history of ASD already. What are the symptoms and signs? So some of them might be completely fine. It might be just an incidental finding that is picked up as part of NIPE. So I don't know whether you guys know what NIPE is. So it's a newborn infant physical examination. So it's an examination that is done to all babies born in the UK. It's kind of a mandatory thing that's done within the first 72 hours. And it's just like a head to toe examination. And as part of that, you will also auscultate the heart, and maybe a murmur might be picked up. And that's how you start off the whole investigation of, is there something else going on? They might present with recurrent chest infection. They might be short of breath, in particular on exertion. They might have difficulties feeding. Parents might notice that their child is quite tired or lethargic. Arrhythmia or atrial fibrillation or palpitation later in life might be noticed. So what are the signs? They may go on to develop pulmonary hypertension. The reason being, as I said, because of the hole being present between the atrium, left atrium is pumping now blood into the right atrium. So at any given time, you have more volume in the right atrium, which means more volume in the right ventricle at any time. So therefore, more volume has to be pumped from the right ventricles through the pulmonary artery, and that can increase the pressure over time and can lead to pulmonary hypertension. Eisenmenger syndrome is a very rare condition and usually develops quite late in the condition, especially if it hasn't been treated or hasn't been noticed. And what happens here is, over time, because of the increased volume on the right side and the increased strain that's put on the right side of the heart, the pressure on the right side starts to increase, and then all of a sudden you get a reversal of shunting, and you now get blood being pumped from right side back into the left side. Heart failure, as I mentioned, you're putting excessive strain onto the heart that can lead into heart failure, right heart side failure or left hand side failure together. What kind of murmur would you hear? You would hear a fixed ejection systolic murmur and a split second heart sound. So what does that mean? So if you know, our normal heart sound is lup dup. Lup being it's the closure of the tricuspid and the mitral valve, whereas the dup, the second heart sound, is usually due to closure of pulmonary and aortic valve, and that usually happens simultaneously. But as I mentioned earlier on, because of the atrial septal defect, at any given time, you now have more volume on the right-hand side than you would expect. So therefore, you have more volume that needs to be pushed through the pulmonary valve than in aorta, and that's why you have a slight delay in the pulmonary valve closing and giving that second heart sound being split. Does that make sense? If at any point, guys, I'm going too fast or you're not understanding or you want me to repeat anything, please just stop me and I will go through it again. What can also happen is, because of that flow from left atrium into the right atrium, it can create a turbulent flow and can create an embolism. And what can happen now is that because of the ASD, sometimes the embolism can enter the left atrium and can get into the systemic circulation and can cause a stroke. Whereas if there would have not been an ASD and an embolism would have been formed anyways in the right atrium, it would have gone into the right ventricle via the pulmonary artery, actually into the lungs, and would have caused a PE. Yeah, I hope that makes sense. How do we diagnose? So the diagnosis would be, let me see whether it comes on. Okay. Sorry, guys. Can you see it?
I can just see the title at the moment.
Nothing else?
No.
No. Okay. So what I will do is I will just see. So yeah, I'll just go through like this. So the diagnosis would be an echocardiogram that will just show whether there's an abnormality, and that's where you will pick up the ASD. It will also kind of show you where exactly the ASD is and the size of it. You would do an ECG, which might show a PR prolongation. We know that the PR is the electrical impulse created when it goes from atrium to into the ventricles. So you get a PR prolongation, you might get right axis deviation or left axis deviation, and a right bundle branch block. How do you manage it? If it's small, and as I said, in the majority of the cases, the reason why an individual child might have ASD is because of the foramen ovale failing to close. And you might just watch and wait, and it eventually will close up. If it's large enough or it doesn't close or the individual is symptomatic, you would close it either with cardiac catheterization or open heart surgery. Let me just go to the next page. Sorry, guys. There we go. Okay. The prognosis, generally, the children do quite well, but they will need like a long-term follow-up if it has been repaired, just to make sure that it hasn't reopened and that they're doing well and they're not becoming symptomatic. If we went for the watch and wait process, then it's just to monitor the symptoms and signs and to see whether they may need any intervention or not. Okay, so that is ASD. Any questions on ASD? Okay, I will just move on. So ventroseptal defect is a defect in the ventricles, between the right ventricle and the left ventricle. Again, the hole can be either small or could be large. Individual can be asymptomatic or symptomatic. And again, it can be either an isolated finding or could be found in association with other conditions like tetralogy or Palate. And again, this is a picture of our normal heart. So as you can see, the septum separating the right ventricle and the left ventricle is appearing completely normal. Whereas in ventroseptal defects, you can see the numbering 1, 2, 3, 4. That's the hole in the septum that's dividing the right ventricle and the left ventricle, and as a result allows blood being shunted from left to the right. Again, you can divide VSD into subtypes based on where the defect is, and if it's a muscular defect, it's a defect in the lower muscular part of the ventricle. If it's perimembranous VSD, it's in the upper part of the septum and most common site. You could also have inlet VSD, which is like a hole near to the tricuspid or mitral valve, and may also be part of the AV defect. Or you could have conoventricular VSD, which is a hole just below the pulmonary and the aortic valve. So again, causes, in majority of cases, we do not know what causes VSD. Sometimes it could be genetically linked, so might be associated with syndromes like Down syndrome, or there might be also some environmental contribution. Again, individual might be asymptomatic and might be just an incidental finding as part of examination. They might present with poor weight gain, difficulties with feeding, shortness of breath, chest pain, palpitations, again, pulmonary hypertension, similar concept to ASD, heart failure, Eisenmenger syndrome, paradoxical embolism. And the murmur that you would hear with VSD is a loud, harsh, pansystolic murmur on the left lower sternum, and a thrill might be palpated. How would you diagnose? Again, echocardiogram to give us a guidance on the size and the severity and whether there's any valvular abnormality, an ECG to show whether there's a right ventricular hypertrophy, and a chest X-ray. Because of the constant strain that is put onto the right side, you might end up with cardiomegaly and increased pulmonary vascular markings. And sometimes you want an MRI heart just to get a better view of the anatomy. How do you manage it? Again, if it's small and if it's less than 5 millimeter and the child is otherwise well, again, it's a watch and wait, and eventually it will close up. If they develop any complications like high blood pressure or heart failure, you would manage that medically. And obviously, we said failure to thrive is another indication, and so high calorie diet is something that you have to look into as well. And if it's large enough or the child is symptomatic, then you would again correct it surgically, either with cardiac catheterization or open heart surgery. So, all fine with VSD. So, just a recap, ASD is a hole in the septum dividing the right atrium and the left atrium, and VSD is a hole dividing the right ventricle and the left ventricle. And depending on the size and whether the child is symptomatic, management will be guided. Sometimes you will just watch and wait, and sometimes if it's large enough or the child is symptomatic, you would usually treat it surgically. Okay, all fine so far? Okay, I will just move on to the next topic, coactation. So what is coactation? So coactation is a narrowing of the aorta. So we know the aorta is the part that pumps blood from that allows blood from the left ventricle to be pumped via the aorta to all parts of the body. And the aorta can be divided into kind of three parts: the ascending part, then the aortic arch, and then the descending arch that then becomes a thoracic artery and then supplies the lower part of our body. Coactation seems to be slightly more common in male than female, and there's an increased risk if there's a family history, and seems to be commonly associated with Turner syndrome, which is probably the most common syndrome that we are aware of and that might come up also in exams, VSD, and bicuspid aortic valve. Again, the signs: individual with coactation might present with an ejection systolic murmur and with a split second heart sound, pallor, difference in the forelimb blood pressure in the arms being slightly or in the upper body being higher than in the legs, cool periphery, hepatomegaly, or rib notching. Symptoms might be that they have a poor weight gain, poor feeding, recurrent chest infection, sweating, and chest pain. So again, we do not know exactly what causes coactation in some children. It might be genetics, and it is sometimes thought that when the foramen ovale, the hole that is present during the fetus circulation between the right atrium and the left atrium, closes as the baby takes their first breath when they're born, the fibrous tissue might extend and kind of wrap around the aorta and can cause the narrowing. So that is thought might be a pathophysiology. And the common area that it affects in the aorta is the juxta aorta, and that's the part of the aorta that kind of folds backwards inferior to the chest and just before it branches off to the head and the arms. How do you diagnose it? So obviously history, examination, investigations where an ECG might show left ventricular hypertrophy, a chest x-ray that might show cardiomegaly, an echocardiogram that actually shows the anatomy and the severity of the aortic narrowing. And again, you probably would do a CT MRI scan just to get a more detailed structure abnormality. Okay, so how would you manage it? So medication would be with prostaglandin to keep the ductus arteriosus open on severe cases. Surgical, so cardiac catheterization, so to open the narrowed part of the aorta and to stent it to keep it open. Or you might do an end-to-end anastomosis, like similar to like colostomies, where you sometimes remove the affected part of the aorta and then join the proximal and the distal end together. An arch advancement is when aorta, after the narrowing, is advanced and anastomosed with the ascending aorta. You might also use subclavian flap aortoplasty. It's a patch or portion of artery that may be used as a flap to expand the area. Complications, you can get a restenosis. You might have high blood pressure and the individual might need long-term antihypertensive. And as part during the surgery, you might cause damage to other organs due to perfusion problems. And as a result, complications could be recurrent chest infections, left ventricular hypertrophy or left ventricular heart failure, coronary artery disease, hypertension in the upper part compared to the lower part, aortic dissection, renal disease, aneurysms in the brain, stroke, or death. And then I think that would be the last part on cardiology. And this, we are moving on from acyanotic condition to cyanotic condition. And anyone, I think you might have already seen, can tell me the characteristics of tetralogy of Palate. What are the four main abnormalities that you see on the fetal heart circulation or on the heart that makes you to think it is tetralogy of Palate? Anyone? Okay, that's fine. So tetralogy means tetra, meaning four. So tetralogy of Palate is characterized by four defects, and it's usually present at birth. And the characteristic features are that this individual will have a ventroseptal defect. They will have a right ventricular hypertrophy, pulmonary artery stenosis, and overriding aorta. And sometimes what can happen is they might have a fifth abnormality, and that's an ASD. And here you can see the abnormality. So you have a thickened right ventricle. Then you have a stenotic pulmonary valve. And then you can't really see it like a ESD. And then you have an overriding aorta, like an aorta that kind of runs over the right and the left ventricle. Okay, so how do these individuals present? They present, as in our first case, or similar to our first case, with cyanosis, so discoloration of their skin or the mucosa, and in particular when the child becomes quite agitated or upset, that's when they might present, and a pre and postductal saturation that might be low. Usually it's picked up antenatally as part of like fetal anomaly scan, and if it's picked up, then further scans will be done, fetal echo will be done to detect the cardiac abnormality and to find out exactly what abnormality is present, and that allows for parents to kind of like allow them to kind of like understand that the child might need a bit more support when they're born. It allows the child has much more intensive follow-ups during the pregnancy, or the mom has intensive follow-ups, and the child is born in a center where they can treat or act quite quickly if the child becomes unwell. And then at birth, you would examine the child. They might be born completely fine, but then they might become cyanosed. You might pick up a murmur or pre or postductal saturation, and obviously you would do an echocardiogram. How would you treat it? So surgically, you might have to do an open heart surgery, a patch to close the VSD, opening up the narrowed pulmonary artery. You might do a total repair. Sometimes you do a shunt, like a small tube is placed between the right ventricle and the pulmonary artery in a way to increase the blood flow. Valvuloplasty, so sometimes you can have also damage to the pulmonary artery, and that is to kind of like treat that. So complications during the surgery, you might have that the surgery might not be very successful. You might damage the SA node. So we know that that's the pacemaker in our heart. And as a result, the individual might become bradycardic and they might need a pacemaker. They might be at risk of infections, either like from the wound itself or pneumonia, cardiac effusion or endocarditis. Renal failure or brain damage as a result of a poor perfusion during the surgery. Mortality, again, it's a very little risk. Long term, they usually do quite well, but they need extensive follow-up to make sure that none of the complications reoccur, in particular the pulmonary valve stenosis, or that there's no regurgitation. If that's the case, they might need a valve repair and might need to go on to anticoagulation. To monitor for any arrhythmia, so ask individuals about any chest pain, palpitations, and heart failure, again, may occur, and if that's the case, they may need diuretics or beta blockers. So as I mentioned before, these individuals will be followed up their entire life. Some of them might need antibiotics prophylactically if they are undergoing certain procedures, and some of them might also need limitation in terms of the activities or exercise that they can perform. And generally speaking, if a child had tetralogy of Palate when they were baby and it has been repaired and now they are adults and they are pregnant, generally they're still considered as low risk pregnancy, but the child might need much more closer monitoring just to make sure that the child is doing well. So we are going on to scenario 2. And the question is, we have baby Samuel. He's 7 months old and was born at term by normal delivery. He had coriasis symptoms for the last 2 days. He feeds now less than 50% of his volume and has reduced urine output. What is the next management? Reassure and discharge, reduced volume and increased frequency of feed, NG feed, or CPAP. And I will open the poll and you guys can vote. I will give you guys some time. I think I can start the timer. Okay, perfect. So actually what you would do is, so the main thing to think about, they're 7 months old and they had coriasis symptoms and they're now feeding less than 50% of the volume and they have reduced urine output. So what you worry about is, are they not getting enough fluid? Are they dehydrated? Yes, reduced volume and increased frequency of feed might be an option, but probably the best option here would be NG feed. Okay, just to support them to recover. And what does this child have? Our little Samuel has bronchiolitis. So what is bronchiolitis? Bronchiolitis is a lower respiratory tract infection. It is most commonly caused by respiratory syncytial virus, also known as RSV. Most commonly occurs before the age of 2, most commonly seen between 6 to 9 months, and usually during the winter season between November to March time. What do we think causes bronchiolitis, or what is the underlying pathophysiology? So upon infection with the RSV, there's an inflammation, and that in the airway epithelium that can cause edema and mucus secretion. That in turn can cause damage to the airway epithelium and can cause either partial or total airway obstruction. It can cause atelectasias, distal airway trapping, ventilation or perfusion mismatch. And the signs and symptoms. So the children usually, or the babies usually present with the initial stage of where they generally do not look very well. They have a runny nose and they're just a bit not their usual self. And then over time, what parents then notice is that they're not feeding as they would do. They develop a cough. They're more irritable. They develop like sometimes breathing difficulties. In very rare circumstances, they might even develop apnea. And apnea is usually defined as holding their breath for more than 10 seconds. Alongside with that, they might have a low-grade pyrexia, and on examination, they might have a global fine inspiratory crackle and a high-pitched expiratory wheeze. In majority of the cases, these babies do quite well, but some of them might need hospital admissions. And when would you admit them? So if they have apnea, if they're feeding less than 50% and you're worried about dehydration, they just appear quite toxic and unwell to you. They have signs of respiratory distress. So signs of respiratory distress could be like nasal flaring, tracheal tuck, intercostal or subcostal recession. So what it means is like the muscles between the ribs that kind of get withdrawn inwards when they take a breathe in. They might be cynosed and the sets might be less than 92% on room air. So how would you manage them? In majority of the cases, it's supportive. But some of these babies, especially if they have reduced feeding, especially less than 50% of their volume, they're not peeing, they do not look very well. You have to think about NG feeding and IV fluids. And if they especially have respiratory distress, what you do not want is like feed them and make them more like upset and distressed and make the breathing worse. So that's why you would probably NG feed them. If their SATs is less than 90% and they're more than 6 weeks old, you would consider oxygen. If they're less than 6 weeks old, then your cutoff for saturation is less than 92% when you would give them oxygen. If they have signs of respiratory failure, you have to consider CPAP. And another thing that is nowadays considered is palivizumab. It's a monoclonal antibodies that is given to babies who might be at risk or children at risk who might catch RSV and might have not a good path in terms of their disease progress. Okay, they might become unwell, quite unwell with RSV. And those children would be children who, or babies who were born preterm and are less than 6 months at RSV season. Children who are less than 2 years old and who require treatment for BPD. So BPD stands for bronchopulmonary disorder in the last 6 months, or children who are less than 2 years but have hemodynamically significant congenital heart disease. So these are the children where you would consider palivizumab simply because you think these are babies or children at risk of getting RSV and becoming quite sick with RSV. Okay. So prognosis, as I said, majority of these babies do quite well and they resolve. It says 3 weeks. It's mainly that the cough might take longer, but the baby themselves might get better within a week. Only about 2 to 3% of babies with bronchiolitis and may need to be hospitalized. And the symptoms usually peak at day 3 to day 5 of the illness progress. And usually what you will see is that the baby gets worse before they get better. Yeah, fine. Now we are going to move on to scenario 3. I hope you guys are all okay so far. Any questions? Okay.
No questions from me.
Okay, perfect. So next scenario. So we have 2 years old Angelina, who was noted not to be herself in the last few days. She has developed a seal-like cough and noisy breathing on inspiration. So her father was concerned and brought Angelina to A&E. So what is the scoring system called to assess the severity of this particular diagnosis? Wesley score, Puce, or traffic light system? And let me open the poll so you guys can vote. Yep, so the correct answer is A, Wesley score. And what do we think that this little Angelina has? So let me just make sure I don't. Okay. Our little Angelina has croup, and the main key in that stem of the question was that she had a seal-like cough, or sometimes known as barking cough, and noisy breathing, like a stridor on inspiration. And this was the key in the stem that kind of should let you to think, oh, it's likely to be croup. And to assess the severity of the croup, that then in turn helps you with the guidance of that then guides you in terms of how you have to manage them, is the Wesley score. Pew score is our score that we use to score the vital signs. Apgar score is usually done at birth, where we kind of score different features like respiration, heart rate, skin color, tone, and breathing. And that kind of gives us an idea of how well the child is doing. Traffic light system is usually used in sepsis, where you have like green, amber, and red colored. Okay. So what is the most common pathogen causing the illness? Respiratory syncytial virus, parainfluenza virus, Bordetella virus, H influenza, or tetanus? And I'm going to open the poll and you can vote. Yep, so the correct answer is parainfluenza virus. So croup is commonly caused by parainfluenza virus. So Angelina is noted to have frequent barking cough, stridor at rest, and marked retraction. She is in significant distress in A&E. What is the best management? Admit to ward, oral dexamethasone and nebulized epinephrine, discharge home with safety net advice. And I will open the poll again. Just let me stop. Yeah, I think the poll is now open. Yep, the correct answer is C. It's oral dexamethasone and nebulized epinephrine, because of the frequent barking cough, stridor at rest, and the marked retraction would categorize, as per the Wesley score, this baby or this child as moderate, and you would probably give them oral dexamethasone with nebulized epinephrine. Okay, just a quick recap on croup. So croup is an upper respiratory tract infection in comparison to bronchiolitis, which is a lower respiratory tract infection, and mostly affects the larynx and the trachea. And the commonest viral illness is parainfluenza virus, but it can be also caused by other viruses like our RSV, which also causes bronchiolitis, adenovirus, measles, and so on. It is commonly seen between 6 months to 2 years, and it's worse in winter or at nighttime, and usually lasts 3 to 5 days. What are the symptoms? So initially the child might present with cold-like symptoms, and then they go on to develop stridor. So it's particularly on inspiration, you get this characteristic noisy breathing. Okay, I would mimic it, but I think I would be very horrible in doing it, so I won't do it. And it's usually worse with crying or agitation. They usually have a barking cough. They might have a hoarse voice, fever. They have increased work of breathing. And moving on to the severity. So this is how you can categorize the severity of croup, or I can show you the next slide where we have the Wesley score. So that's the Wesley score. And these are the categories that you use. So and you score them. And then based on the scoring system, it tells you whether they're mild, moderate, or severe. And Angelina would fall under moderate. So she had a frequent barking cough, stridor at rest, mild to moderate retraction, no or little distress or agitation. And the treatment would be a single dose of oral dexamethasone and nebulized epinephrine. And then you usually monitor them. And to be honest with you, from clinic practice, oral dexamethasone is a magic. And especially children who are quite well, the dexamethasone does a good job, and we might just observe them for a bit and then can discharge them home, obviously with safety net advice. How do we diagnose croup? Usually it is a clinical diagnosis, but if you are not too sure and you are considering differentials and you're doing a chest x-ray, the characteristic finding on croup is this steeple size. Can you see it? Yep. The narrowing of the upper airway. That is a characteristic finding of croup. Okay. The other things that you obviously have in mind, if particularly a child comes with stridor, epiglottitis, and inhaled foreign body. So it wouldn't have been wrong if you guys also thought it might have been epiglottitis or inhaled foreign bodies. How do you manage them? So supportive, dexamethasone, nebulized adrenaline and salbutamol in some cases, oxygen if they have low SATs. Obviously, you don't want to distress the baby more, keep them hydrated and let them recover and rest. Okay. What are the complications, which is quite uncommon, is that on top of the viral infection, you get like a bacteria infection, and that's then called bacterial tracheitis, and it's quite life-threatening and need urgent antibiotics treatment. You can have otitis media, or they can go to develop airway obstruction because of the virus causing edema and inflammation and mucus that can cause airway obstruction. Okay, so going to the next scenario. So now we have John. He is 6 years old and was brought by his mother, as for the last 3 weeks he has early morning cough and shortness of breath when swimming. It started off when he was 3 weeks ago. I do not know whether you guys saw it already, but what further questions would you want to find out from the mum? Anyone?
Maybe ask that if it's just all exercise or if it's just swimming specifically.
Yeah, that's good. Yeah. What else?
Family history.
Yes, correct. That's correct. That's good. Anything else? So yeah, you guys are going down the right path. So obviously you want to find out more about the general well-being. So in peds, what you always want to find out is like from the birth. So you just want to find out, okay, how many weeks were they pregnant? Were they preterm or term? Was it a normal delivery or was it a cesarean section? If so, why? And was there any issues during the antenatal period? And then obviously, how have they been prior to this episode? So yeah, in this case, the mom was saying that he has been well, but when he was 4 months of age, he developed a rash under the flexure regions, and that was after breastfeeding, but it resolved at 2 years of age. But he then went on to develop allergy to eggs and develops urticaria. And as someone mentioned, family history, and his older sister suffers from eczema and rhinitis. So going to the next question. So what is the best next investigation? Reassure parents and explain likely resolving viral illness, symptoms diary, peak flow, fractional exhaled nitric oxide, spirometry. And I will open the pool. Okay, I think it's my bad. I actually should have phrased of what would be the actual best investigation to diagnose it. And actually the answer would have been spirometry. So because you would do probably all of it, but because they're 6 years old, they might be okay to do a spirometry. And spirometry, what it involves is that you ask the child to take a deep breath in and to breathe out as forcefully and as fast as possible and breathe out fully until they can't breathe. And in this way, what you're measuring is by asking them to breathe forcefully and as fast as possible, you're measuring their forced expiratory volume in 1 second. And by asking them to continue breathing until they kind of like they're out of breath, is you're measuring the forced vital capacity. And then once you have these two values, so also known as FEV1 and FVC, you can calculate the ratio, and it gives you a picture of whether it's an obstructive picture or normal picture or like a restrictive. And as you probably already guessed or correctly, this child has asthma, and asthma is a obstructive condition. And so what you would expect on a spirometry is that the forced expiratory volume in 1 second is lower than you would expect for the child of his age or her age. And so that's what you would see, and that would be the way to diagnose. But obviously you would ask them to keep a symptom diary, you would ask them to do peak flow, and you in some cases where, for example, you do a spirometry but then the history or the examination does not go quite well with the diagnosis of asthma, you might do a fractional exhaled nitric oxide. And what that involves is that it's again a device where the child breathes into, and it measures the amount of nitric oxide. And in children, I think if it's more than 35 parts per million, it is diagnostic of asthma. And why it is because nitric oxide is produced as part of inflammation, and in asthma it's an inflammatory process, as we know, and because of that they might have high level of nitric oxide, more than you would expect in a child who does not have asthma. Yeah. So what is the best first line of management? Low dose inhaled corticosteroids, short acting bronchodilator, medium dose inhaled corticosteroids and short acting bronchodilator, low dose inhaled corticosteroids and short acting bronchodilator, watch and wait. Yep. What would be your answer? Correct. So there has been a constant change in the asthma guideline, and actually what you would do in the child who's 6 years old, you would start them a short-acting bronchodilator, but you will also give them a low-dose inhaled corticosteroids. Yeah, so D is the answer. So yeah, just quickly on asthma. So it's an irreversible obstruction of small and medium-sized airway, and that is due to eosinophilic and neutrophilic inflammation, and due to contraction of the smooth muscle in response to various stimuli. It seems to be a condition that is caused by multiple genes and an environmental interaction, and there's an association with other atopic conditions like eczema, rhinitis, and food allergy, and that's why it's very important to ask about personal history and family history, and it seems to affect 1 in 11 children. What causes asthma? Again, we do not know the exact cause. There's this hygiene hypothesis that we are too focused on being very hygienic, so that our body is not getting used to antigens and is not able to kind of detect harmful and non-harmful antigens, so it's starting to even react against antigens that might not be harmful to the body. Okay, then we have the allergic march. So in some asthmatic patients, what you can see is that when you kind of look at their from the childhood until the presentation of asthma, they have other atopic conditions, like they might have had food allergy when they were younger, then develop eczema, and then rhinitis. It doesn't always have to be the case. Sometimes you have asthmatics who do not have any of these, or vice versa. You might have children who have food allergy, eczema, and rhinitis, but do not go on to develop asthma. But that's something that you should have in mind. And then another theory is that filaggrin gene is a gene involved in the skin, that you might be kind of like exposed to certain antigens that might be exposed through the skin, to which our body reacts to, and sensitize lymphocytes that then can react against the airway epithelium and can cause chronic inflammation. So what are the signs and symptoms? So they might have triggering factors, what could be signs and symptoms? So they might have a polyphonic expiratory wheeze, which sounds like a whistling sound. They might be short of breath, chest tightness that in younger children might be presented as tummy pain. They may also present with either nighttime or early morning cough and reduced peak flow. And different individual might have different triggering factors. Some may have one, some may have multiple. So that's why it's sometimes important to keep a symptomatic diary, especially if you're in the process of kind of diagnosing and getting on the hold of like managing the child. It's important to know what triggers it, okay? Because you want to avoid those triggering factors. How do you diagnose? As I said, it's a combination of factors: history, examination. You will keep a symptom diary, trial of steroid inhaler, and that's particularly for children under the age of 5. That's how you usually diagnose asthma. Spirometry, fractional exhaled nitric oxide, and a peak flow meter. And peak flow meter in particular is very useful to see how they respond to treatments or new treatments, and also during acute exacerbation. It might be very helpful to know what their baseline is and what their current status, to see how bad their current exacerbation is, to kind of get an idea. In some cases where you're not very clear about the diagnosis, you might want to do a chest x-ray and allergy skin testing. So the management would be to avoid triggering factors, use correct inhaler technique. So that's always very important at any circumstance when you get like a patient with asthma, like either with asthma exacerbation or they come for annual review. Always important to find out whether they know how to use the inhaler. And it's always very important not just to ask, do you know how to do it? Just also ask them how to show it. Because some people say, yeah, I know how to do it, but then actually when you look at the technique, they might not do it as it should be. And it's quite a hard technique, even though we think, oh, it's very simple step sometimes, but it's actually quite hard. So it's very important that you watch and see and make sure that they have a good inhaler technique. And it might be simply the inhaler technique being why the child is not getting better. Again, as I said, peak flow meter, smoking cessation, weight loss, update, make sure that they're up to date with their immunizations. So like flu vaccination is something that children with asthma would be recommended, and they will have an annual asthma review just to see how the child is doing on the current management. And it's not only to see, okay, are they struggling and do we have to go up the ladder, but it's also to see, okay, are they managing fine on the current treatment, and can we actually go a step backwards? So that's also good. We also have to think about cutting down on medications to allow better quality of life and adherence. And this is the table with the management that I got from the NICE CKS. So the management slightly varies based on the age. Okay, and that's where we are. So devices that we can use a spacer with a pressurized metered dose inhaler. That's particular if the child is between 5 to 12 years old and they may not be able to coordinate the inhaler technique. And so with the spacer, you can either use a face mask or mouthpiece. So if they're younger, you would use a face mask. In that way, they just have to breathe in and breathe out. And on the other end, you attach the inhaler, you press it, and then by breathing in and breathing out, you're allowing the medication to get into their airway system. If they're a bit older, rather than using a face mask, you can use a mouthpiece. And then obviously, if they're more of like an adolescent, you might use the inhaler itself. So here you can see the face mask, spacer with the face mask, a spacer with the mouthpiece. And then this is just the pressurized meter dose inhaler. Dry powder inhalers are not used. I haven't seen it, to be honest. So this is where you kind of like have like small tablets that you can put into this device, and then you press it and then it generates like a aerosol that you kind of breathe in. So are we okay to carry on?
Yeah.
Perfect. Perfect. Okay, so next scenario, we are still with John. He's 8 years old and he has been well managed now and on low dose inhaled corticosteroid and short acting bronchodilator, and he last used his reliever 1.5 years ago. He now presents to A&E with wheezing and chest tightness. What would you do next? ABC approach, observation including SATs, if well enough, peak flow meter. Correct. So you would go for an ABC approach because the child is quite unwell, wheezy, chest tightness, and I think the best way to approach any child with in the A&E with asthma, always start with A to C assessment, ABC assessment. And obviously you would do like observations, including SATs as part of your ABC, and you would also do a peak flow meter, as I mentioned earlier on. Always good practice if they're well enough, just to get an idea of, especially if they know their baseline, to know what their peak flow meter is at the moment. Okay. John is using his accessory muscle and saturation is 89%. His peak flow reading is 49%. He started to vomit. What is the next best management? High flow oxygen, back-to-back nebulizer, salbutamol nebulizer, back-to-back salbutamol and ipratropium bromide nebulizer, oxygen driven, corticosteroid, I use prednisolone, corticosteroid hydrocortisone. Correct. And back-to-back salbutamol, ipratropium bromide nebulizer, oxygen driven. Very well. Because obviously the SATs is below what you would want. So you want to be given oxygen, and they're using accessory muscles, and it looks like an acute asthma exacerbation. And the way that you can help them is via nebulizer rather than inhalers. And you would do back-to-back salbutamol and ipratropium bromide. What back-to-back means, just because I didn't really know at the beginning, it just means, so you give salbutamol, like a dose of salbutamol, followed by directly ipratropium bromide, again salbutamol, ipratropium bromide, and salbutamol. So you give 3 doses of salbutamol nebulizer, in between you give ipratropium bromide, and then this nebulizer is then oxygen driven rather than air driven. Okay. Then next case. So how is John doing now? So John had back-to-back salbutamol and ipratropium bromide nebulizer, oxygen driven. He feels better, but is still using accessory muscle, and his saturation is now at 91%. What is the next best management? Magnesium sulfate IV, IV salbutamol, prednisolone, hydrocortisone. Let me just see what options, how many options we have, and theophylline. So the right answer is actually hydrocortisone, and the reason being, prednisolone would be also right. So you would give them steroids, but the reason why I'm saying hydrocortisone is prednisolone is given orally, and hydrocortisone is given IV. And as we remember earlier on, we said that John has been vomiting. So the risk is that if you give him prednisolone orally, that they might just vomit it out. So therefore, you would give them hydrocortisone. And obviously, if they're not doing very well on all these treatments, the next step would be a magnesium sulfate. Okay, so now John has received hydrocortisone, has been admitted and has been weaned off his nebulizer on the ward, and he's ready to be discharged. What is the next step on discharge advice? Okay, and the answers are: you give him a weaning plan, asthma review in 2 days, review his inhalers, discharge home with no advice, discharge home with advice if he requires his inhaler every 2 hours for 4 hours, or requiring frequently his inhaler, then to seek medical attention. So yeah, the correct answer is E. And the reason why I particularly put this scenario is because there has been a recent change. So until quite recently, and even now in some trusts, we give weaning plans. So what we say is, if you feel like they're well enough to go home, and they're usually on 10 past 4 hourly, what we then say is, okay, when you're home, then maybe wean down to 8 past 4 hourly, 6 past 4 hourly, and then like reduce the frequency until they're off their inhaler. But what has been noticed with this weaning plan is that as a result, parents might feel like, oh, okay, let's just wait for a bit and see how they respond to the weaning plan, and then go if they don't respond. So there might be some delay in seeking medical attention. So therefore, what they have said is that if you use your inhaler more often, or you have to use like your 10 puffs like every 2 hours for 4 hours, or then come back. So by not having like a fixed regime, you're making sure that the individual come back home, to hospital earlier before it gets even worse. Okay, so severity of asthma. So we can, as we know, classify asthma severity as mild, moderate, severe, or life-threatening based on the saturation, respiratory rate, the use of accessory muscles, how well they speak. So are they talking full sentences, or are they not to talk at all? What is their conscious state? Okay, so the acute management is that you aim for an oxygen sats above 95%. You would give them salbutamol nebulizer if it's mild or moderate severity. Ipratropium bromide nebulizer might be joined together as in our scenario. And again, in a recent paper, they published so-called super nebulizer, which is that alongside with salbutamol nebulizer and ipratropium bromide, you also add magnesium sulfate in the nebulizer, and that seems to be quite helpful. Again, your steroids, IV salbutamol, IV max sulfate. Again, in terms of IV salbutamol, IV max sulfate, see what, like if you work in hospitals as F1s, F2s, or at any grade, always check the trust policy and guidelines. Some prefer to use IV salbutamol as a next step, some prefer IV magnesium sulfate. And obviously, if none of these then help, you have to think about theophylline. Okay, then we are almost getting to the end. So now we have Ananya, is 3 years old and appears very sick. Her mother reports that she suddenly became short of breath. And this is our little Ananya, who is in this characteristic posture. Can someone tell me what you call this posture?
Is it called tripoding?
That's correct, yes. So it's kind of like a hunched back and hands forward, just to kind of in a kind of leaning forward to try and being able to breathe. So they look quite unwell. So the scenario is, what is the most likely diagnosis? Foreign body, epiglottitis, croup, bronchiolitis, burn injury, i.e. safeguarding. Correct. Epiglottitis is the right answer. And the key features on the question was that they're appearing very sick, it was of a sudden onset, and the tripod posturing. And one thing that I purposely avoided in the STEM is that I did not say that the mom didn't immunize Ananya, because again, we will come to that in a second why. It's an important aspect. Okay, and what is the most likely pathogen causing it? Candida, strep pneumonia, H. influenza, varicella zoster virus, herpes simplex virus. Correct, it's H. influenza. Oh, sorry, I didn't expect that. So yeah, the right answer is H. influenza. So epiglottitis most commonly caused by H. influenza, but all of the others can cause epiglottitis as well. And I mentioned earlier on that I purposely did not talk about immunization, that Ananya wasn't immunized, and H. influenza is part of the 6-in-1 vaccination. And it's very important in peds that we always ask for immunization history. And that's one of the main difference in history taking between adults and in peds, that you asked about the immunization history. And again, at this period of time, it's very important that you ask about immunization, because more and more parents are not very keen in immunizing their children. So it's very important to know their immunization history. So what is the best next management? ABC and IV access, chest X-ray, laryngeal fibroscopy, call for anesthetist. So I'm going to stop there. So the right answer is actually D, call for anaesthetist. The reason being is the child is already very distressed, is quite unwell. They're probably already toxic appearing and their airway is probably very like occluded. The last thing you want is going close to the child, trying to put like a cannula in, them screaming off, and then the airway getting occluded and you needing to manage the airway. So therefore, it's always important that in epiglottitis, before you even go near to the child and do any investigation, make sure you have appropriate support to maintain the airway, because what can happen is that anything that you can do, they might become very distressed and the airway get occluded and you might lose the airway and you have to manage it. So therefore, you want to have the appropriate support before you treat them. Okay, that's another key thing they wanted to mention with epiglottitis. So as I mentioned, epiglottitis is the condition that our little Anania has, and it is caused by inflammation of the epiglottis, either due to infection or due to throat injury. As I mentioned, the most common cause is H. influenza, but other pathogens like bacteria, fungal, viruses can also contribute to epiglottitis, but also throat injury like burning from hot liquid or smoking like cocaine or crack can also lead to epiglottitis. How do these children present? They might present with drooling, painful swallowing, hoarse voice, muffled voice, stridor, irritability and restlessness, severe sore throat, and difficult breathing, which is improved on leaning forward. That was the tripod posture that I mentioned earlier on. Management, secure airway. Okay, depending on how unwell they are, they may need oxygen, intubation or tracheostomy, IV fluids, antibiotics. You might want to do further investigations like fiber optic laryngoscopy, throat swab, and bloods. Some cases you also want to do a chest X-ray or CT scan to check the level of swelling. So that's all. Thank you very much for listening. I hope it made sense. If you guys have any questions, please feel free to ask me.
That was such a helpful lecture. Thank you.
Thank you.
If people are watching on YouTube, please do fill in the feedback as well. We keep them open for a long time, and it's really helpful for us to get as much feedback as possible so we can make it more useful for you and just know what you're thinking. But yeah, thank you so much, Kalpana.
Thank you so much.